nobody in this room is going to learn anything with this. This is old news, but just a different remix of the way things are. And I promise not to talk about any off-label use of devices. Didn't work too well for this guy. Now, I want to talk very quickly about a couple of cases. They're very similar in their presentation. This is a 55-year-old woman with hypertension, some palpitations. She's had episodes before. She had a cardiac catheterization some years before, doesn't know what it showed, didn't know what it was for. And she's coming along with a wide complex tachycardia, 210 beats a minute with preserved blood pressure, and we got an ECG, and there it is. Now, everybody in this room glances at this and says, what's the big deal? This is SVT, right? But it was fast and wide and scary to the people in the emergency room. So they said, no, this is VT. And gave her lidocaine and gave her amiodarone, and that proved the diagnosis, right? Because if it terminates with amiodarone, it must be VT. So they recommended that she have repeat catheterization and an eventual defibrillator. Well, this is a concealed left lateral accessory pathway. She didn't need any of that stuff. And it was not very mysterious at the time of her EP study. All right, another case, 55-year-old man. He's had palpitations and lightheadedness like she did. He's had a heart catheterization, but he's had several, no previous episodes like this. He had a cath, didn't know what it showed. He's going only 140 now. Preserved blood pressure, doing well. Here's his wide complex tachycardia. Again, everybody in the room glances at this and says, it's a big deal, this is VT. No, not so easy. This was diagnosed as SVT, okay? Adenosine, more adenosine. Verapamil, because the adenosine didn't work. And all of a sudden, they're scraping him up off the floor because he has no blood pressure, because this was VT. And somebody with previous inferior infarction is very evident here. Now, what are our choices? I teach my trainees, if you don't have a list of the differential diagnosis, if it's not on your list, you're not going to diagnose it, unless somebody hands you a piece of paper with a diagnosis on it. So our possibilities are SVT with aberration, crazy-looking QRS to begin with, somebody who's drug toxic or electrolyte toxic, SVT with WPW, VT, of course, ventricular pacing, and not on the 12-lead ECG. I've never seen a good 12-lead ECG of artifact, but that's convincing. But a rhythm strip is very common for artifact. And I spent many years getting some of these examples, so I'm going to show it. Here's left bundle pattern, right bundle pattern, V1 and V6, and all these different classifications here. And to the novice, and there are none in this room, they look pretty similar, right? They're all pointing down in V1, okay, but they're all a little bit different, as we'll come back to. We're only going to talk about the 12-lead ECG, of course. There's physical maneuvers and physical examination that are still very valuable, and you can impress a lot of young people with those. But in most series, you don't even need to see the ECG. If somebody just describes, I've got this person with a wide complex tachycardia, you say, stop, it's VT. How do you know that? Right here. 65%. You're right 65% of the time. You can't do that in the lottery, right? And if they say, well, no, I don't think it is, and say, well, it's SVT. Because you've got everything else is very small, right? So our main problem then is distinguishing between these two. How do you do it? Well, I like things simple. So I ask the question, does a QRS look like any form of aberration that you know about? Because I used this example the other day. Michael could hand me a shekel or a piece of paper that has shekel written on it, and I said, well, it looks pretty good to me, because I'm not so smart about what shekels look like. And I know what a $20 bill looks like with Alexander Hamilton on it, but I don't know shekels so well. So if you know what real is, what aberration really looks like, you're not going to be fooled by something that doesn't look like aberration. That's easy. Okay, so if it looks like aberration, probably SVT. If it doesn't look like aberration, then it's probably VT. Okay, that's simple. How do we do this then? Well, several years ago, I was asked to write a chapter on this very topic. What's there new to add to this? Well, I looked back at Wellens' stuff from 1978, which is still great reading in those 115 or so cases. But it's been 30 years since then, and a lot has changed about how we manage patients. And I thought, well, maybe we ought to take a look and see how things are different or how they're the same. So we looked at 650 wide complex tachycardia ECGs in 385 patients. All were obtained at EP studies, so we knew what the diagnosis of each arrhythmia was. And it's a pretty standard mix, structural heart disease, most of them post-infarct. And the distribution is the same as everybody else, about 75% VT. And we looked at all these things here, the usual stuff. We're going to dismiss rate for now as being unimportant as a differentiator. But QRS duration, axis, precordial concordance, QRS morphology in V1 and V6, and AV relationship are all useful tools. And we know that if it's greater than 140 milliseconds, it's going to be VT, and less than 140 milliseconds, it's likely to be SVT. Well, why is that? Well, you can't have wide complex tachycardia unless it's at least 120 milliseconds, but the further it gets beyond 140, the less likely it is to be just aberration. It's likely to be more slow propagation than you can have with just aberration. Left bundle's a little bit, will allow it 160, 150, 160. But you have to be careful in people with structurally normal hearts, their VT can be relatively narrow, and people with structural heart disease can have SVT with wide QRSs, or those with antiarrhythmic drugs. And this is the old stuff from Wellens, I won't spend more time on that. You see that the SVTs and the greens and yellows are narrow, and the VTs are distributed, but mainly wider. We looked at our series compared to what Hein had seen, and his was a pretty sharp demarcation, but not all of our VTs were, not near as many as the VTs were so wide, and a smaller portion, very much smaller portion of our SVTs were narrow. I don't know, why is this? It's still pretty good positive predictive accuracy here. Positive predictive accuracy, if you extend it out to 160 milliseconds, is better, but not perfect. And we thought, well, why is this? Well, younger patients are showing up with VT in the absence of structural heart disease. We did ECGs on these folks. And older patients with structural heart disease are living long enough to have atrial arrhythmias, flutter and fibrillation, and other types of SVT. And looking at the left side of the ECG, at least in America, we read them left to right. Maybe not around here. The axis is important because if you're more negative than minus 30 degrees, most are ventricular tachycardia, certainly if it's pointing towards the right shoulder. It's very difficult to get there with any combination of bundle branch block or hypertrophy, any way you can do it. Now, we have a county hospital where we are, just a regular inner city hospital, and for some reason, there are a lot of people who run the ECGs that can't get left and right correct. So we have a lot of limb lead reversals on these people. So it is possible to do that way, but it's kind of fun sometimes. But it really makes it much more complicated. If you've got an abnormal QRS to begin with, this is really out the window. It's very difficult to interpret that. And you see these axis, normal axis is very relatively uncommon during VT. Left axis deviation, much more common during VT, and so on. And this northwest axis pointing towards the right shoulder, where leads 1, 2, and 3 are all negative, very good still as a predictor of VT. And we found also that in the Hein and Mark just reported this earlier, the left bundle with right axis, right inferior axis, extremely uncommon during SVT. If you see this, I've seen one example of it. So it's a very high positive predictive accuracy. Contrary-wise, right bundle with a normal axis is very unusual in VT. Common in SVT, but unusual during VT. Why that is, I don't know. I've got only a few examples of that. The concordance and the precordium is great. There are only a couple of ways you can do this in the absence of SVT. It's not easy to have negative concordance in SVT, but you have to be careful with a couple of situations. And these are useful, but not very prevalent in VT, so only about 20% of VT has anything approaching concordance. Positive concordance, negative concordance, everybody's familiar with this. And I've chosen these two examples. This is VT with positive concordance and WPW, creek-sided SVT with positive concordance. It's hard to tell these apart. There's some little changes here and there, but it'd be very difficult to distinguish these two. And the AVR algorithms have tried before without much success, unfortunately. In our series in 2006, we found that 18% of VTs, a larger proportion, had positive concordance, but a significant proportion of SVTs did as well. But look here, the negative concordance just doesn't separate at all anymore. And that's curious. And we thought maybe, and we need to look at this a little bit deeper, but SVT in people with structural heart disease, heart failure, and left bottom branch block can certainly present, and probably that's a mechanism for this blurring of distinction. And then everybody knows about the SVT and VT criteria for lead one. Mark Josephson popularized this way back. And the fundamental distinction here is that these are, whether you have left bundle or right bundle during SVT, the initial forces are preserved, initial vectors are preserved, and in the absence of SVT, where you're going slow propagation muscle to muscle, the initial vectors are perturbed or perverted, depending on how you want to put it. But they're in good shape here and messed up over here. In V6, I won't spend much more time with this. Everybody knows about the RS ratio in V6 being a very good predictor and why that is. This is what Mark Josephson and Betsy Kinwall, one of my fellow fellows, put together in 1985. 1988 it was published. And these are qualitatively very similar in R wave and a deep S wave, fine. But in fact, this is a narrow R wave and a wide R wave, preserved versus perturbed initial forces. And getting from the onset of the QRS down to the native S wave is relatively fast here, relatively slow here, greater than 60 to 70 milliseconds. And again, we come with this diagram here, and it's pretty easy to see, looking at what we just saw, that this onset of QRS to the width of the R wave is much wider than, say, over here, or we don't even have an R wave here, but it's very rapid descent to the nadir of the S wave, very slow descent to the nadir of the S wave here. And these are subtle, but very easily quantified and very useful distinctions. The AV relationship, very helpful if you see dissociation, but you don't have to see that. You can see second degree block, either 2-to-1 block or VA Wenckebach, but it's not very helpful if it's a 1-to-1 relationship, obviously, but you can't distinguish them. Or if you can't see P waves because of atrial fibrillation or flutter, or just too much QRS and ST segment T wave to be able to see. We looked at our series in 2006. This is Wellens' series, and even, now this is just looking at the ECG, I could only designate a 1-to-1 relationship in 50% of these ECGs. Even, well, knowing that we had intracardiac recordings, but just off the ECG, only 50%. And 43% were indeterminate. That's not very good for an electrophysiologist, but that's the way it was. Now, if you combine all these here to dissociated P waves, 2-to-1 conduction or Wenckebach, about a third, almost 40%. You can see this with VT, but never with SVT. So that's obviously very statistically significant. Sometimes we think it's one thing, but you've got to make sure you're not overlooking the obvious abnormality here. And this is an ECG that passed through a lot of hands at my institution as being probably SVT. And those who thought it was SVT didn't have a real good explanation for this here or this over here. And certainly on the rhythm strip, especially with the aid of arrows, you can see these P waves that are obvious and march out other ones that are not obvious. So it's very clear that this is dissociated activity here. So the diagnosis should have been easy, and maybe it should have been easy with the axis or with the presence of Q waves or the RS ratio, any number of ways to get the right diagnosis, but a lot of people miss this. Now, fusion and capture beats, we look for these all the time. It is a very frustrating search. I know because the next example I'm going to show, I went through 1,000 ECGs to 1,000 white complex tachycardia ECGs to show a good capture lead. But it's just another manifestation of non-one-to-one conduction, retrograde conduction during VT, sneaking in a supraventricular complex. Don't look for it in very rapid tachycardias. It just can't get through the conduction system quickly enough. Then I've seen a couple of cases, I'll show one here, where a PVC during SVT can cause fusion. Now that's a rare one, but it does happen. Now here's my one example. Full capture leads every once in a while during VT. Very slow VT, almost not tachycardia, but there they are, very obvious. And here's the intercardiacs of that same patient in another tachycardia with a nice fusion beat, complete with dissociated A's and retrograde hisses during VT, but here's one that is anterogradely propagated. Here's my one example of a right bundle SVT with a spontaneous right ventricular PVC. How lucky can you get? And it narrows the QRS. It doesn't normalize it, but it narrows it. So if you just saw this, you'd say, hey, fusion beat, must be VT. Not so fast. All right, now, this is still called the new criterion, Brugada. This is 20 years old now, a little bit older than that. And this is the absence of RS complexes in precordial leads. Now, here's left bundle aberration, right bundle aberration. You get RS complexes in each of those situations. So the absence of an RS complex is, again, does it look like aberration? No, because you usually have RS complexes during aberration. So their algorithm went like this. If the RS is absent, then it's VT. If you don't have that, then look at the RS interval. If it's greater than 100, then it's VT, so on and so forth. And then the usual stuff. And they found, wow, 98% overall accuracy. That's pretty good. Their original question didn't sort out too many, and even their second question only got about 40% of all the VTs, and then they had to resort to the usual stuff. That's still pretty good, but you know, Brugadas are pretty smart guys, and not everybody can reproduce their findings in many ways. Here is one study that some folks did using cardiologists blinded to the diagnosis and emergency room physicians. The actual paper said EPs, emergency physician. And so they found that the cardiologists did better than the EPs at diagnosing this. And I said, wait a second, what's this? But it's emergency room physicians, all right. So they were as low as 43%, whereas the Brugadas were 99 and 97%. So I send all my top ones to Pedro and Ramon and Joseph. Now, if you have a pre-existing bundle branch block, it messes up these criteria substantially, and Alberca and some of the other Spanish guys have published extensively on this. Now, newer criteria. We published a couple of different papers in 2007, 2008. This is a Hungarian fellow who was very interested in this and collected a lot of ECGs from our lab and elsewhere, and came up with this very, very complicated, painfully complicated algorithm here. Looking at just look at it here. So this is the beginning. You take a QRS complex that's got a lot of ziggles to it here, and you look at the number of millivolts in the first 40 milliseconds versus the number of millivolts in the last 40 milliseconds. And if there's more in the front part, that means it's moving faster, faster conduction, and therefore the ratio is going to be more than 1. If it's, look at this one here with the slower propagation, less voltage in the first 40 than in the last 40, that's VT. Okay, boy, I said this is too hard. I didn't take myself off the paper, but I thought this was pretty hard. This is how it works. And he included this last criterion way down here at the bottom as a final discriminator using AV dissociation, and we'll talk about this AVR business here in a second. Yeah, that's pretty good, but this hasn't been prospectively, it hasn't been published, but it's been prospectively analyzed. We have something in publication now. Then he looked at the AVR, single lead. Everybody's got an AVR to look at. In SVT, they tend to look like this, very sharp initial forces. And again, qualitatively, these are similar, but quantitatively not. And so during VT, these initial forces and in fact, the entire direction, just almost never see this R wave here, monophasic R wave and AVR in normal people. And this this is in the paper, the explanation for it. Here was the algorithm, initial R wave in AVR, then a Q or a small R wave that's broad, notched Q wave, all of this is in AVR, all these guys. And then finally sorting out to this crazy thing here. And again, it's pretty good in 482 wide complex tachycardia. It's not perfect. And then the newer criterion. This is from just last year, Pava in Spain again, and some colleagues. I was up in Hamilton, Ontario last year, and they showed me some funny ECGs, and I was sitting next to Carlos Murillo, and I said, you know, there's this new paper out just a couple of months ago. He said, yeah, I'm the second author. Thanks a lot for remembering. It's a little bit embarrassing. But what they did was looked at a single lead, lead 2, D2, and looked at the onset of the QRS to the time of peak voltage, either positive or negative, and say if it's more than 50, it's likely to be VT. If it's less than 50, it's likely to be SVT. That's pretty easy. Tested in only 218 ECGs, did pretty well. It's just a receiver-operated curve, very good inter-observer agreement. And here's how it works. Here's a VT from onset of QRS to peak, very long, peak negative, very long. In SVT, very short, very short. And here's their algorithm. We're done. You know, if it's greater than 50 milliseconds, it's VT. You don't have to go all the way down here to the rest of them. And it's, I estimated these from the receiver operator curves that actually have the numbers in the paper, 95% overall accuracy. But be careful, because in this case here, it'd say, okay, 40 milliseconds, SVT. But if you look at lead 1, oh, changes everything. So it's important to look at those simultaneous leads and make sure you know where the QRS starts. It's easy to find this spot here where the peak or the nadir is, but be careful about where it starts. And then finally, just a couple of things here. If your bundle branch block is opposite of what it was during sinus rhythm, of course, most people come to the emergency room in their wide complex tachycardia. They don't say, oh, by the way, I have right bundle during sinus rhythm, my left bundle tachycardia. Sometimes the QRS looks different during slightly different during the wide complex tachycardia than during sinus rhythm. More people are carrying around a wallet card with their ECG on it nowadays. Important that, you know, everybody in this room knows this. Hemodynamic stability is not the same as SVT, but how many times a year or even a month do you have to reiterate this with the primary care physicians or ER docs? There's just a person with right bundle during sinus rhythm and left bundle during wide complex tachycardia. Any number with this right inferior axis and broad R wave. In many ways, this is VT. But if you knew that they had right bundle branch block in sinus rhythm and then they blocked their left bundle branch, that's a bunch of P waves if they had SVT. You don't have any QRSs in. And in fact, we looked at our experience in people with left bundle SVT, none had baseline right bundle branch block. And if they had right bundle SVT, none had baseline left bundle. It's a pretty good discriminator, but then you have to know what the resting ECG looks like. And then there are these funny things here. This very wide RS, it doesn't know whether it wants to be a right bundle or left bundle, therefore it's not aberration. And this W pattern is very, not so common during VT, but just never seen during SVT. And so it all comes down to this original question, does it look like aberration? All the algorithms get to this similar point in different ways. If it does look like aberration, it probably is. If it doesn't look like aberration, it's probably VT. And we still have some problems. We've got a lot of people running around with very wide QRS complexes nowadays, with drugs, with heart failure. And do these criteria still apply to those? We don't know. It hasn't been prospectively tested. Are there features of the right bundle QRS initiation, beginning of the QRS that we can pick out, like with the left bundle? Don't know. And how can we simplify our criteria? Maybe this lead 2 is going to be the answer. I don't know. So in summary, we can usually get to the right answer by asking the question, does it look like aberration or not? Even if you don't know that, most in the community are VT. And people should be approached as though they had a more serious diagnosis. And we still don't have an ideal method for just one-stop shopping so that everybody can get it. I appreciate your attention. Go out.